So, Dr. Nenov, let's present the case.
Hello everyone, let me present the case. It's about 50 years old male patient who is with high-grade effort angina. The patient is with 3-vessel disease. This January he was with myocardial infarction inferior, and we performed primary PCI of the right coronary artery. Risk factors: hypertension, dyslipidemia. From ECG we have sinus rhythm with Q and negative T waves in inferior leads. From echo, preserved left ventricular function with about ejection fraction 53. With basal and mid-segment inferior akinesia, the wall thickness is 6 millimeters. No severe regurgitation. Here you can see the right coronary artery, the final result of the stenting. And in spite of view, 50% stenosis of proximal circumflex artery and one bifurcation LAD diagonal branch 111. We performed dobutamine stress echo, and we have 4 segments inducible ischemia in LAD region and inferior cicatrix. That's the case.
Okay. So, comments from the panel, what we have to do?
I think the first we need is to have more projections and to take time to look in details if the lesion we see in proximal LAD diagonal is also going down to the ostium of LAD. So it will become a second bifurcation, the left main. So this is, we have to look in details and discuss with, maybe they will show now, yeah. So the first thing I will ask is at least 3 projections on the left. Other comment about that? Hello? In the cath lab?
Has the aortic curve?
Juan, do you hear me?
Perfect. And then
we have a connection.
No, he said perfect, but not to me. Juan?
hello.
Hello, Juan. How are
Good
you
morning.
this morning?
Good morning.
So-
we are just starting the case right now.
Yeah, we were looking a few injection in left coronary arteries. And what we need to understand which case you will perform now is to have at least 3 good injections on the left.
On the left, exactly. We just checked that the right coronary artery kept a good result from the last acute coronary syndrome. And now I guess we can go directly to the point.
The right is okay.
How do I move the...
No. I'll help you.
This one?
Oh, what's this?
Very good. Very good result in the right coronary artery, and we are trying to, 35 more or less. With zero inclination. Okay. And I guess, do I have the control of the? You do it for me. Perfect. Let's feel the coronary artery.
Press.
A bit to us. Yeah, perfect. Maybe a bit more to us because the bifurcation. Okay, perfect. Feel a little bit the coronary artery. Please, small
40.
injection. Small injection.
40
Okay.
cranial will be better.
40. We have
5 degrees
35.
more.
5 degrees more. Let's learn from the experts.
What we call epicranial. Yeah,
Epicranial.
What's my preference? Okay.
Okay. Because the more inclination, the more radiation.
So yes, but this is just to fix the strategy. After that, we won't need it.
No problem. So, recording. Open the door, close the window. So, what do you think?
I will do the contrary. I mean, caudal, a lot of caudal.
Caudal.
And after that, maybe a spider.
Spider. I'm not very sure what...
Spider, I'm not sure too. It depending on what we see on the ostium of the LAD.
Yeah, you are right. Let's check. I still think that we could assess the...
If you rotate a bit to left, you will have the whole beginning of LED inside the trachea here. So this minimize the X-ray and you will have better picture.
Yeah. Okay, so filming,
Filming here.
perfect. Dun, dun, dun.
So yeah, we solved the problem of proximal LED. Ostial LED is normal.
Yeah,
So it means that the lesion will treat on the bifurcation. Won't be necessary to put a stent towards the ostium LED. Excepted
I think so.
is ostial LED is a proximal segment is no longer than 8, for example. Because you know when you do a bifurcation, you need place to put to do a pot in just crossover stent
Yeah.
you do. So we need at least a measurement of the proximal segment of LED.
Okay. Let's film here. Let's film here. Okay. Yeah, and one again. Okay.
Yeah, it's nice. It's
Here,
nice.
here the proximal part looks. Our strategy we discussed yesterday was doing IVUS and just assess how tight the stenosis were, whether we have a landing zone in the proximal part, which now angiographically seems we feel confident without IVUS about that, and essentially just to settle the strategy about the bifurcation stenting.
In my place, we will use an angio guidance only. But no, leave it. Do it. I will explain while you're doing with IVUS. I will explain how we'll do without IVUS.
Perfect. So that will be totally educational. So my suggestion is going back to the 35 degrees. In the
35.
you control.
Yeah,
I
this
see.
is the controller here.
I see. So
35 cranial.
that's why I could not move the system. 35 and then we can use as reference the first projection we did of the LED,
Yeah,
which is
but it was
50 degrees. So this is the typical question you make in a bifurcation meeting. Would you protect the side branch? And now you can poll the audience and see how many ones would protect the side branch, yes, no, etc.
Who will protect the side branch? The diagonal, yeah.
Yeah. I am with Yves. So maybe
Yeah, what we see is two diagonal. You probably know the concept of side branch clinical relevance,
Yeah.
which was raised by Dr. Koo. It's not a single diagonal. This is not the first. So it's possibly not supporting more than 10% of myocardium. So the matter today this morning is to protect it and to, in case of problem.
One question from the panel. Why you?
Or
Excuse
DLD
me.
or whatever. Yeah.
Question from the panel, full advance. Listen, why you decided to use IVUS and not physiology like FFR? Because looking at this artery, I think it's absolutely negative FFR. Then just a question. You are the operator.
This question is for us or for the panelists?
For you, exactly.
That's for you.
Absolutely for you. Posso farlo anche in italiano se vuoi, però.
Possiamo parlare in italiano, ma non
No,
sono
vabbè,
sicuro.
Let's go in
I'm
Italian.
not sure whether the audience will follow us.
No, in English, it's okay.
So that was one of the questions yesterday. Absolutely, it's the right strategy as well to guiding the revascularization, the completeness of revascularization in this patient after STEMI, guiding it by physiology assessment. And actually there is strong evidence about that. But we felt so confident that the lesion would be significant that we thought, okay, it will be probably more useful to guide the intervention having an IVUS system. In the past, we used the IVUS also to decide the severity of stenosis in the LAD. And we had a cutoff of 4 millimeters, square millimeters, just to decide about the revascularization. But this strategy is not valid anymore. It has disappeared from the guidelines. It's only valid for the left main with a different cutoff, 6 millimeters of mercury. And about the decision of revascularization, if we do not have a proof of ischemia, that would be the right approach. But I mean, yesterday, all the discussants felt confident about the high likelihood that the lesion would be relevant, that we thought that would be more educational, just showing with IVUS how we select the sizing of the stents, how we select the balloon for pot, and how we check the final result, because we intend to use a kind of novel technique invented by Bulgarian interventional cardiologists. But you are totally right. Probably I did not convince you.
No, you completely convinced me. I mean, you started with the idea to make angioplasty, and obviously you planned the procedure with IVUS to make it IVUS-guided angioplasty. Absolutely, you convinced me. Thank you.
We can show a picture with after the nitro.
After the nitro. That's okay. So let's feel the coronary artery, and maybe we can move now. Since we are going to center in the lesion, we can. Yeah. Do we film? Ready to film?
Yeah.
Perfect. Film. Okay. I'm filming. Okay. This is after nitro. Maybe.
So I know you will do IVUS, but personally I see very well all this projection that I can put a crossover stent, maybe beginning 2 millimeters, 1 millimeter after the end of the beginning of LAD, and covered down to the 5 millimeter after the diagonal branch. And so it won't be necessary to follow back to the left main. But if you look at this picture, you will see the left main is not normal.
Yeah, the left main is.
So we may have, maybe as you are having a look with IVUS, look at the left main will be interesting too.
Yeah, we'll perform the pullback.
And of course, my procedure will be crossover stenting. Based on the distal diameters. If somewhere in the cath lab somebody is able to measure the diameter in the normal part of the LAD distal to the bifurcation, and immediately at the ostium of the LAD with a caliper compared with a 6 French guiding will be interesting for me.
You mean by QCA right now?
Yeah.
Okay. Is that possible in the cath lab? Measuring by QCA the diameter, distal and proximal to the bifurcation?
Yes, but someone has to do it for us outside.
Yeah, that's perfect. Just give me the data.
And we'll ask Dr. Gelev. But during that time, we're preparing the assist IVUS.
This session will be recorded in English. Open the door. Close the window. So, we are waiting for the IVUS connection. So, in the meanwhile, I guess you probably will agree that we can consider this lesion Medina 110, or would you say 010? This is also some debate we had yesterday.
Yes, but as the lesions are short, it is not a real matter, because if a 010, the treatment will be the same as 110, a crossover stenting. What is important is that the diagonal has not a tight lesion at the ostium, so no discussion about treatment of the diagonal first.
Yeah, that's true. It makes no difference in the strategy, but just maybe to highlight how difficult it is to have a reproducible assessment of the Medina classification in an ordinary setting, in a normal setting. Because, it depends. If you see the angio moving,
So 110, maybe 111, because the ostium of the diagonal is also not normal. But, you know, this lesion is short, and there is no reason not to use a provisional stenting.
Yeah, complex two-stent technique. Yeah, that's clear. So we are going to use high definition IVUS. I think This is the ASIS system. Correct me if I am wrong, but I think it's 45 megahertz, the ASIS system. We have a 60 megahertz system in Boston Scientific. But ASIS is...
For the QCA, begin very at the initial part of the LED there. Yeah.
Yeah.
A bit distal, even a bit more. Okay. So what's the measurement proximally?
The proximal MLA are reference diameter approximately
3.6.
of...
And the distal is... I'm not interested by the stenosis. Don't worry. Just the distal.
2.8.
The distal normal measurement. 286. So just an information, a Kubo trial, a Kubo work, the team of Patrick Saroys a long time ago said that QCA is undersizing measurement by 5%.
What is the problem of this QCA
So the
assessment?
360, you had 5%. You can calculate.
What is the problem of this measurement we just did? Both of you mentioned it yesterday. This is a QCA assessment for a cylindrical coronary artery, not for a bifurcation. So it's not adjusted to Finette's law, to a bifurcation. In order to assess the true severity of the lesion, the true
3.1?
stenosis, we will need to apply bifurcation dedicated software, which is not, probably it's available in a console.
So the target diameter with the stent and the balloon we choose will be to reach 3.8 millimeter. And the target for the distal will be 272.
So
273? No. Distal at 306, yeah.
Thank you very much. I have the...
Well, without using QCI, just looking at the angiography, the stent should be 3
Will be
millimeters.
3.2. So
and
3.8
the proximal part
and
of the pot 3.5. Now we'll see the result of the IVUS, which is much more interesting.
To do rain down, right?
So waiting for the IVUS, my strategy will be to choose a 3.0 stent. For the length, we can also measure, or use the radio opaque part of the guide wire, and we have with the pot we'll reach a diameter of 3.8.
Here comes the sun.
So I will give you another information later how to get this diameter.
It's difficult to...
3.8 proximally, 3.2 distally, normal segment.
Cannot understand why. Because we have two wires.
Eva, you are with the 6 French guide?
Let's remove the second
It's
wire.
a little bit
Yeah.
tough
You're
with
right.
the second wire.
It will be
Okay, we will
a little
remove the
bit
second wire.
difficult later on with 6 French
something
guiding with such
cannot do
big
with,
arteries, because
with the high
the side
definition.
branch
I
is
forgot.
more than 2.5.
Because I usually
I think.
not using this system. Okay, we have to remove the second wire to do the IVUS in 6 French. Important detail we did not take into consideration. This is possible with
Fari,
solid state IVUS, but
what
not
would
with
be your
rotational
strategy
systems.
in this? This is a cliche, but how would you approach this? I mean, in every day, if you are not live.
Okay, well, for sure I will do IVUS because I like this bifurcation. I want to treat it, so I will use IVUS. This is the first thing that I will do, and probably either the angiography and the IVUS will say that the diagonal is not to be touched, so the provisional stenting. And pot as the bifurcational club says, and after that, if I have a problem with the diagonal, I will put something like a tap, for example.
What means problem with diagonal?
The problem with the diagonal for the people is that you have a slow flow and suffering diagonal and dissection, very long dissection, or mostly important is the flow in the diagonal. Using IFR, FFR on the diagonal after the angioplasty is not my case. I will do IVUS because I have the IVUS inside the cath lab for this case before the procedure. So the diagonal will be treated if there is a problem with the diagonal, as I said, with the flow. So let's see the IVUS now.
And this is
It's
the
a good
proximal
IVUS,
part.
almost OCT-like IVUS,
Yes, this is
high definition one.
high definition IVUS, yes, it's very,
Now,
very good device. Do you make automatic or manual pullback?
no, automatic. High definition is only possible by automatic pullback. Rotational systems, so this should be the ostium of the aorta, which has apparently no disease. Okay, I guess we are done. We are done. We disengage the catheter specifically to see the ostium. Now we can review the pullback. Can you see the pullback in the audience?
The huge advancement advantage of this system is that there is a sheet, outer coverage of the
Now I come back
detector
with the guiding catheter.
of the sensor, and it remains
Pull back. The catheter
inside the
goes-
artery. So you can make a lot of introduction or pulling back the IVUS catheter without
can try to keep it,
any
and
risk
then we assess
for
the result.
some traumatizing
have time.
the vessel wall, just because the sheet is in place and
Deletion. The carina.
you're yes.
Question to the operator, why you remove the second wire from the diagonal?
Because we
There
are
was
working.
crisscrossing of the wires.
Yeah.
Because there was a
The
problem. Okay.
six French system, rotational IVUS is slightly thicker than the solid state, the Volcano IVUS. With Volcano IVUS, you don't have this precision we can see here, but it's thinner, so you can work with two wires in 6 French,
Oh, yeah.
but not with the rotational IVUS systems, especially the high definition, neither Boston nor Assist. And we forgot that detail.
Because I like to have a second wire in the diagonal
No, we
with the
will.
IVUS. It's a very good to as a wrapper, as a marker.
Yeah, we will, no question. We will, the
No,
second
no,
wire
for the
will-
marker. Okay.
No. So distally we measure 3.03 diameter in the distal lesion, in the
So
distal
this is
reference
absolutely
vessel.
the same, like a calculation.
Yeah. And let's see proximally, just for the pot and so on.
Depending
So-
on where it is.
Interesting, the highest plaque burden in IVUS is proximal to the bifurcation. So angiography is totally misleading regarding the distribution of the plaque. See, the highest plaque burden is proximal to the bifurcation. Our Medina 110-111 became all of a sudden 100. So we have a minimal lumen area of 2.6
Yes. it
here,
is
which is,
tight
according to all
stenosis.
published studies, high likelihood of being significant. Although it's not the criterion that we have to follow currently. Yeah, and the stress echo was positive. So that was another argument. Sorry, I forgot to decide to do IVUS because we had a positive stress test. Okay,
With a
so
huge
can
amount
we
of
measure the
matter in
EEL or approximation of the EEL and the proximal part to decide how big the pot balloon? Yeah, here for instance.
4.5.
Yeah. Bit distally. Yeah, that.
This
That would be the
Near
circumflex.
the left
Let's
mass.
measure here the EEL.
Here is
Just
okay,
to have
but
an idea. Okay.
probably
Okay.
you can measure
so it's,
the lumen area in this case.
3.93, so it's approximately 4 here. So I guess we can implant a 3.0 stent and then potting with 3.5. Okay, because we
small.
need to
Yeah,
upsize.
3.5 for me is okay. So
Yeah.
what is the diameter, the diameter you measured proximally?
Proximally, the diameter is between the minimum is 3.89 and the maximal 4.
3.89. Yeah, that for me was 3.8.
Can we measure the lumen,
But
Valery?
the maximal diameter is 4.39.
Yes, but this is
so
media to media. Can we measure the lumen?
Excluding the plaque.
can we, okay.
That's a good question because in this kind of lesion, we can have expensive remodeling. So
Yeah.
that's why sometimes when you follow the data of IVUS, and especially media to media, you may close the side branch. And I have seen that
Yeah.
in China, in the group of Chao Yongshen, an expert,
exactly.
This occurred.
Exactly.
In a
So
normal
let's insert the
circumflex, it
second
was
wire
closed
that we
because
had to remove.
of this measurement.
Second
So
wire, and then we
remember,
implant the
a
stent.
vessel can have positive remodeling at the level of the lesion.
By 28, or you're
So-
going to measure the length?
And what we are treating is
yeah,
really
the length,
is
I
a
guess with
lumen
12
is
all the way
normal
15 to
as
pot
the same
safely.
diameter as a true normal proximal diameter. This is the good target. So 40 will be too big for me.
Yes, 40 will be too big now because the lumen is 325 to 377. So at the mid, it's 3.5
Here comes the sun.
as a
Here comes the
mean
sun.
value between the two. So 3.5
Circumflex.
will be good for pot. Just
Yeah.
otherwise, if we go, if we
Yeah.
follow media to media,
Yeah. In
could
this
occur
case,
a lot of problems.
yeah. One of the advantages of IVUS is that we will check the result afterwards.
Yes, and
so
also-
we can play in the safe part. In case of hesitation, we can go for the smallest balloon, 3.5 in this case, maybe a small test.
So
and
another
then-
information I wanted to give you, I said it was the value of Dr. Kubo for undersizing of QCA by 5%. In a phantom, not in a patient, IVUS is oversizing by 8%. So you
Yeah,
have to remember
yeah,
that.
yeah, torque
The
maybe,
true value
because
is
the
obtained
wire
only
is
with
a
OCT.
bit-
A bit damaged.
a bit, yeah, it's more difficult to control as it was before. Yeah. No, it will. I don't expect much problems, but
So we
Let's
have
see.
agreed about the. Is this still true, the oversizing with the new IVUS? Because this is a 60 megahertz, so
Yeah.
that's much closer to OCT.
yeah, I see.
This I don't know. So Juan,
Yeah, I can give you.
the IVUS you are using, is
Yeah.
it still oversizing the diameter as was the first version?
Yeah, I mean the oversizing of IVUS depends on the frequency, and so the IVUS will always oversize as compared to OCT, and even more as compared to coronary angiography, because of the physics. I could give a very nice talk for physics freaks about that. So high definition IVUS is going to oversize less than solid state IVUS, which is 20 megahertz. But still, there is significant oversizing as compared with OCT or with angiography. So we can implant the stent.
Okay,
The big
3
advantage of
I would
this
say
IVUS is
15.
that it could
15 has
work
to
in
give
two
some space for
frequencies,
the
in
bolt
40
inside the
and in 60 megahertz. And in 60, practically it works almost like OCT, but it loses some advantages of the IVUS regarding the deep penetration, but it is much more accurate for the lumen assessment.
we have to cover
So
the first
if they want,
diagonal also.
they can
I
use,
think
they can
that
switch
is
the
better.
working frequency here, because the machine is mechanically arranged on 40 megahertz. It works on 40, but manually it could be switched to 60. And if they have some doubts about the stent position, and this IVUS is very good regarding this assessment, and there are several regimes, different regimes of work, especially for the lumen delineation or even for the plaque. It depends on what you want to assess with this machine.
Dobry, this is absolutely necessary to use pullback, or you can use it without pullback, for example, to check the bifurcation?
My personal protocol is to use, to do mechanical pullback, and then I'll go slowly back
To repeat,
but I leave the sheet. I usually, I place to the distal part, to the distal third of the vessel, the sheet, and then, you have you are free to move the detector as much as you want, as where you want, just because there is no risk to dissect something or to
But
traumatize
you
vessel.
can make registration also manually, not only.
Yes, you
pull
can.
them. Ah,
You
good.
can do also manually.
Very good, yeah.
You can do it actually with engineers because I work a lot with this IVUS, and with the company we made something off-label, and we disarranged the pullback machine, and we made a modification especially for the manual assessment. And
You can show to me that, okay.
So, Juan, what is, you will pre-dilate with which balloon? 3.0? Or not pre-dilate?
We didn't.
We couldn't hear, sorry, it's a bit loud.
Will you pre-dilate or not?
No, we will try to do direct stenting.
So,
we feel confident.
which stent are you choosing?
For a bifurcation, in this case, which we don't have much concern about longitudinal strain or so on, we would choose one stent with 2 longitudinal connectors. And so we decided to implant Orsiro.
Orsiro, yeah, is interesting for his minimal thickness. And what's the diameter?
3.0, according to the distance.
3.0, can you look at
reference.
the nomogram, how to reach, at which pressure you are going to 3.2?
Okay.
Uh-huh. That's,
Can somebody look at the nomogram? It's on the box normally, 3.2. What is the pressure?
yeah,
The pressure to 3.4,
it's 8, right?
3.2, it's 13 atmosphere.
13.
13 atmosphere.
So, so we have to give 12 or 14. I never
Yeah,
give 13.
what I propose you is to do 2 inflation of 30 seconds at 12 atmosphere, consecutive,
I see.
without
Okay.
moving the balloon. Without moving the balloon.
So we feel confident. We are distal to our target. So in Rukzuk. So
I think it's important the position proximally, huh?
proximal.
Because
Let's check. Yeah, exactly.
Yeah,
maybe we
maybe-
have to readjust a little bit more distal in order to be sure that we are not stenting the circumflex.
To
Small
reach to
test.
45, it is a little bit clearer.
The
version
circumflex.
of LED.
Small test. We can change also the projection. Yeah,
A bit more distal, take
More
care.
distal. Let's change the projection to caudal. and we
Maybe
will see
to
the
check in the
Okay.
caudal.
Caudal, yeah. That's we were, yeah, that's fine. And now we can, So let's test here because sometimes so
bit,
it's
yeah, a bit,
okay.
yeah,
It's
take
okay.
care not to move.
Let's engage a bit better to get more stability.
Yeah.
Test again. So you were right. Open the door. So small test? No, small test. This will be enough, I think, because we are confident that
Yeah,
I
you
bet
can-
we can deploy here.
Yeah. So you go normally, not
12.
quickly, for 30 seconds. Yeva, not less than 30 seconds.
Okay.
Timer died.
So, los. Good expansion. Now we change
12.
the projection for 20 seconds while we have this.
the easy way to understand are you in correct place is just to give a little bit of contrast now, and if you see your circumflex, everything is okay. If not,
and check that the circumflex is
not
free.
this inflation.
Let's
The second one we see. So 30 seconds. You can see that the proximal part is not fully deployed. Huh?
Yeah, it is at 12.
So this is the rule I am explaining here is normally after preparation, because here we will have probably to use a higher pressure. We'll see during the second inflation.
30 seconds, so it
So now you can deflate, we can discuss 1 minute, and you can reinflate again 30 seconds without moving.
stop the timer. But,
A question to Yves, why twice to inflate the balloon inside of the stand? Why
Because
twice?
everybody here in this room may think that a balloon is elastic only. So you have a pressure, it gives that diameter. You inflate 10 times, you have the same diameter.
Yeah, we
This
can
is
do
all-
it again, 20 seconds.
This is also plastic. The
thinking of
second
doing-
time is oversizing the first one by 10%.
the second inflation.
And this one is overlapping the curve given by the company
Doing this,
as a second inflation only.
any technique.
So if you do one inflation, 5 seconds, of course, this is completely crazy.
Okay.
But 30
We'll
seconds,
not.
you are under
the diameter proposed by the company. So you are not on the wall if you have well measured your diameter. So you inflate a second time. Then you have the
So
diameter
this was
proposed by the company.
26,
Some
right?
pressure.
Yeah.
And
now
if
we
you are,
need a
we
3.5,
will show you a maneuver to be sure
15
that
Or 12.
the distal stent is well opposed.
Okay.
for the pot.
Okay, this is the
One
second
timer.
one.
This is the
So,
second inflation
Second inflation is done
for 30 seconds.
for
Yeah.
30 seconds again.
No, yeah. Can you go back?
Go back.
Go back.
Yeah, go back. We'll do a short inflation more. Go back.
More.
One more.
One more. Open the door.
Yeah,
Close
go
the
push
window.
push your balloon again. Okay.
Here comes the
Position
sun.
it in inside the
Okay.
stent, huh?
Okay.
Maybe
Yeah,
a
yeah.
little bit
Inside the
further.
stent,
Further.
and
I'm a bit afraid of.
you inflate
Now,
at 12 atmospheres as usual as the first ones.
Yeah. So
And Juan,
Yeah.
do a gentle injection.
gentle injection.
Gentle
I know.
injection there.
Very
we have not
gentle,
performed
huh?
the pot yet.
What we call a puff. A puff.
Yeah. I was thinking of that.
Okay, this stent is well opposed.
Yeah. I see. Still, we
So
will do the
deflate.
pot. We
So
will
you
do the-
can deflate here. I think this was. So this is the third inflation. Third inflation has not the same diameter as the second one. Of course, there is a limit of this. After
we're ready
three,
Perfect.
they are joining a maximum plasticity. You know.
So
Now we have solved the
he was
problem of
trying
the
to
distal
prove.
segment. To treat the proximal segment, now we'll
I
use
see. It's,
the pot. So the pot we said
the valve.
would be 3.5. Yeah.
They're a
Yeah,
little
it's a
bit.
bit
Yeah.
tricky.
Yeah.
I see. They have become a
If,
bit
can you
sticky.
hear me?
No,
Yeah.
I think it will
So
be
we have
fine.
prepared 3.5.
Then I
This
can-
pot PTCA
then I-
balloon, especially dedicated, it is 6 millimeters long. Although we
Yes,
have
you will
enough
have
space.
probably. It's probably longer than 6. Huh? You will have probably
Yes,
to do.
but anyway, we are going
Stairs,
to
no?
do.
Okay.
No, but the segment to treat.
This one is gel. So
Valerie,
This is the gel.
Valerie,
Yes, yes.
can you look at the nomogram
They were twisted.
of the balloon?
it's not bad.
Yes.
Is non-compliant? How to get 3.8 millimeter?
Well, 3.5.
3.8?
26 atmospheres
Whoa,
is
whoa, whoa, whoa.
3.0.
So that's why you are using a high pressure non-compliant balloon for a pot. We see that in literature, in meetings. This is crazy.
Yeah, this is
Because this is not this is not giving you precise
compliance.
diameter,
No,
the one you
compliant.
choose. So you choose a semi-compliant balloon. You look at the chart and you put the pressure necessary to reach 3.8.
see.
This is what we have to do.
Pressure, 3.8.
Just
I
a
have
couple of comments regarding the pot balloon. This balloon was introducing to me from Xiaoliang Chen, actually.
I know.
He,
He has no cone.
yes, he sent me an email and said,
okay.
we have a friend, we want to introduce it in Europe. And actually, in our lab, we were one of the
Small injections, just
first centers which tested this balloon, not only in Bulgaria, but
Bit distal.
the balloon is without cone. Yes, it is purely cylindrical, and it is really cylindrical. We
This one, the biomarker is not far from the
No.
part of the balloon. This is the
this exactly, yes, it is really cylindrical
this one is okay.
and should be in
I'm
the,
opening.
yes, you should be
Yeah, exactly.
very
Okay.
very precise in
Okay,
position.
don't go to 23 atmosphere. This is crazy. So what you can do here is a small puff.
Press.
Yeah.
It's probably opposed already.
So we have to give more.
No. We have something in the diagonal. No, it's not fully opposed. So
Not
it
fully
will be for another inflation.
Okay. We are still.
Ивана, какво налягане сте?
Let's deflate.
Колко ви е?
16.
16.
But
Дай 25 хубаво.
26 is the
Да.
3.5.
Let's deflate and let's try to go a bit more
Nothing
distal
will happen.
because it moved.
Yeah, but 26 is
Now,
to
here,
to treat a lesion which was neglected before implantation of the stent.
Yeah.
To deploy a stent, you need 2 atmospheres. 2 atmospheres. So
we'll
this
do a
stent,
puff here.
0.5 atmosphere to deploy the stent.
Now it's okay.
So,
Aha.
Is this high pressure balloon is
Still a bit.
to treat the wall, not to deploy a stent.
Okay.
To deploy a stent, we need a semi-compliant balloon to
Okay.
choose the diameter.
My only concern in this case, if is that practically they made direct stenting and they simultaneously dilate
Maybe we can take
and
4
implant the
millimeters.
stent. I mean that this is a direct stenting and they have to really to dilate, not only to implant the stent. This is a
Even for pre-dilatation of a bifurcation, you still can use two balloons.
We can,
One for the distal, one for the proximal. Of course, the distal one cannot reach the diameter of the proximal at the risk of blocking the side branch.
But looking for how the contrast penetrates the side branches and even the diagonal, I think that probably this balloon is undersized. And
Semi-compliant?
yes, maybe 3.5, but semi-compliant now. Now.
5 semi-compliant now, because you open the lesion.
Yes. Now it's
So I think you opened the lesion, which was a bit resisting to the first balloon. What you can do is to go back with a balloon, semi-compliant balloon,
entangled.
at probably 14, 15, 16 atmosphere
What
normal.
I propose is to probably make the kissing, and after that anyway we have an IVUS here, and we are going to estimate what is the what we have done.
Yeah, yes, we can look at that, but my comment, because I said I will explain how to do without IVUS, my comment is that we will have malapposition of the proximal part, the pot, and the distal part will be well deployed, so no problem for the distal part.
Okay. What about making an IVUS now, and after that complete it with a non-compliant balloon as you
I can
propose?
bet that in proximal part the stent is not fully opposed and there are
Yeah.
at least
I think we
3
can-
zones of malapposition.
We can still use a 4 millimeters balloon, semi-compliant 4 millimeters balloon, just to. Unfortunately,
Dr. Mitov,
our
what-
safety wire
would be your approach at this moment?
got entangled in the balloon, and we
I
lost.
agree with new pot with bigger balloon, semi-compliant.
Yeah, with
4.0.
4.0. The IVUS made us feel confident about doing that, and we saw that with 3.5, as if already anticipated, we are slightly undersized. So maybe
You have the force you
we need.
A question, why you are trying now to re-enter in the diagonal branch? I mean,
Yeah,
if your flow is
that's,
okay, just make an IVUS in the stand, and if it's okay, we finish the procedure. I mean, why we have to enter in the diagonal if the flow is okay, if the contrast is passing good?
Yeah, I mean, for safety, every time we go around the carina, we like to. This is the wrong one.
the first one.
Sorry, men can do only one thing at the same time. Women are multitask. But yeah, I mean, the wire is a bit hesitating to re-enter the vessel. But okay. So, thank you. So now we are totally safe. We didn't lost much time in this maneuver. It's a pity because the wire got entangled in the balloon, and we could not help to lose it from the safety position. But okay. Is there consensus in the panel to do a pot again with a bigger semi-compliant balloon?
Yeah, the same balloon, 4.0.
4.0.
Measure, look at the chart, what will be the diameter.
Yeah. 4.0.
We need 3.8, so probably nominal will be enough.
Yeah. My usual approach in the CAD lab is doing the pot with semi-compliant balloons, with normal balloons, because, I mean, in...
The same for me.
Okay. But the kissing with non-compliant balloons to avoid overstretching the proximal part. That's our common rule.
Okay. Да? И още един манометър, да. Okay. Да.
So about the balloon, the plasticity of balloons, this is the same for non-compliant balloons. Of course,
This is
the importance
for
of
all non-compliant,
plasticity is
12 millimeters.
Semi-compliant.
still exists.
Semi-compliant.
Semi-compliant is the balloon.
And between the first inflation and the nominal inflation at the diameter of the industry,
That's fine.
the difference can be 0.2 millimeters.
12 is probably better.
0.2 millimeters, this is 200 microns, and 200 microns is the definition of malapposition.
Okay. The other one was 8.
So guys, you
I don't know that balloon.
decided to
It's not
do a
familiar
second pot
to me. But
and then to do IVUS, yes? Eva?
That was your
we'll
proposal.
find out.
Okay.
I mean, I think Eve was just guiding us. So
Yes.
we are going to do this, and probably after that I was.
So this is
Until-
what...
I have a question. Who in the panel will make a kissing balloon for this
Okay, small test.
I
diagonal?
will not make kissing balloon because I will do a good angiography like that with a good contrast and we'll see. If the diagonal is okay, I will leave the procedure because at my age I stopped to do a lot of
Which was
things
the
in the
chart?
cat lab.
The
look.
chart is
8,
for 9 atmospheres.
30 seconds again.
4.9. Okay, then
So during that,
let's go
this
10.
in my place in Massis,
Okay,
we are
then,
doing that since 2010, 2011.
Okay.
Now it's okay.
So,
Damn it.
so of
Okay,
course,
let's
during
go
that
12.
time, you can discuss your vacation.
Let's go
But
12.
it's a bit longer, but it will add 2, 3, 4 minutes. to the
And
procedure.
then
Unfortunately, the contrast still penetrates behind
Now,
the
well,
behind the balloon.
Test now?
Still, yes.
So, what is it
damn
is a non-compliant?
Yes.
So you see,
Semi-compliant. Semi-compliant.
And
The
we're-
14.
this is a semi-compliant.
Yeah.
14.
This one is a semi-compliant. So what you can do is increase a bit the pressure. You will increase the
Валери,
we
какъв
already
балон
did.
взехте в крайна сметка?
Това е
14.
semi-compliant обикновен балон,
Okay.
4 на
We
12.
achieved
Ah.
4.3.
Okay.
Is it the first inflation?
Okay,
No,
then
this is the
let's-
third
let's
one.
deflate.
The third one, say it.
Third one. I
We
guess.
increased from 9 to
Yeah.
11 to 14.
Yeah. I guess sometimes, especially in calcified lesions, we don't have to be very.
to learn something from
any Very case. Obsessed.
This is a very educational, by the way, because for me,
wait.
this 4-hole
We'll
balloon,
use again
according to
the one.
IVUS, should
I will-
resolve
I will keep both.
any
Yeah,
problem.
I can
I mean,
keep both.
with the, but
And then now,
it's
since
true
they are
that
both free,
the contrast is
it's
still
relatively easy.
penetrating.
We cannot hear you well.
the other way around.
I say that it is amazing that according to IVUS, by doing pot with this 4-hole balloon, the problem with the stent malapposition should be resolved 100%. But what we saw from the contrast puffs, there was still some penetration of contrast behind the balloon. Just contrast penetrated and visualized the diagonal branch and the septal. And this is, for me, it's really unexpected, let's say so. I'm really
Yes,
surprised
but-
and I'm really
However, let me-
impatient to see how in IVUS looks this result.
There is a lot of explanation, but
Yeah,
finally
I have
we
one.
don't have any practical issues with this because we should achieve a good apposition or a good stent area by IVUS that is clearly necessary just for good immediate and long-term results. And there should be an explanation probably because there is a lot of calcium. Probably the vessel is not that circular as it needs to be. So maybe it's an important sign just to correct.
Of
but
course,
it-
it's not forbidden to inflate a fourth time, but or even a bit longer, you know.
12 is okay.
But if you do the puff and you see something, normally you're supposed to do more.
We can use the 4.0 we recently.
Exactly like with IVUS, we see a malapposition, you do a bigger balloon.
Non-compliant. New one because with 6 friends.
Another point is that the best is the biggest enemy of the better, and probably we should not be extremely aggressive just because the next step could be just trying to improve, could achieve some beautiful complication after.
Yeah.
Of course.
May I-
Do you have a stent enhancement in your cat lab? So this is also part of the evaluation of the result when you are so poor that you are not able to buy IVUS or CT. This is, we're not poor in France, but these are not reimbursed. So if you are doing 2,600 PCI a year, and probably more now, it represents a big budget. So, and I'm sure, I know that from data that in Europe, intravascular imaging, it's used in 5% of procedure, no more. So, okay, during meetings, this is very interesting to show IVUS guidance and how precise it is, how we learn something we don't learn with angio. So this is, I agree with this. But if you cannot pay to have intravascular imaging, you have to find other solutions. And one is a small puff, another one is a stent enhancement with 2 projections. You will see.
Yeah. I think the fact that we saw some contrast flowing into the side branch is, I agree with you that it's kind of unexpected because we were very precise with the sizing. However, it could make sense, as you commented, because keep in mind that we had a second wire. So this induces itself some kind of violation to the tightness that we should have. And the contrast needs just a very small space to go through.
Maybe we can discuss what to do with the diagonal, as it was suggested. I will share the position of my colleagues. This diagonal is the second one. It's not a very small one, but I don't think this is an important one. Personally, I will inflate at the ostium. I mean, I put the nose of the balloon inside the diagonal, no more. Because if you push this balloon like this, if you have a dissection, it will be longer.
Then at the side branch we will inflate just.
What is the size of the balloons for kissing?
Actually, we are going to make the most of our IVUS guidance to do a novel technique that you invented yourself, and you named POCI, which is a combination of pot and kissing.
So thank you.
POCI. So
yes,
this was published in a Paramount journal of cardiology with a Bulgarian and Polish series of patients with good angiographic results.
actually,
Angiographic and clinical
Juan made
results.
the first POCI in Germany.
And I did them. I had the privilege of doing my first POCI in Germany, and I did the second one in Ruse under your supervision. We have problems.
Yeah, you have wire twisting. So as the LED is well treated, you can move back the LED wire and cross again. So will be the solution.
Let's see. Because I think
we discussed yesterday
but
this
then
case
I will
with
have
Juan,
more
and
friction when I try to
because
I just need
there was a
couple of- I
plan
just
what
need
to
a
do,
couple
how
of
to
millimeters.
proceed,
Yeah.
and we decided that probably he
Now
wants
if
to.
I put
Yes,
the other
your
one back, the other.
pot
Okay, so the
balloon
POCI,
is exactly in place.
maybe Dobrin can explain himself better
Actually,
than myself.
the point here is to use the markers of the balloons as
Exactly.
markers for
The ones-
for inflation. The side branch balloon proximal marker should be inside the stent. Exactly. Now you're in the best
exactly.
position.
So now
So
the
they're
markers.
kissing markers, the distal marker
I
of the
guess
pot
we will
balloon
inflate this to
and
6 atmospheres,
the
not
proximal
more.
marker of the side branch balloon. They're kissing. You see that they're overlapping at this moment. And this is a moment where you don't need any contrast and so on, because the balloons are exactly at the point of main vessel, side branch, and you reconstruct the anatomical. Yes, this is the problem which can Exactly, the sleeping, yes. So probably, Juan, you should inflate a
reposition.
little bit, yes, a little bit back.
Yeah,
Yes,
yeah.
exactly.
Let's try.
This is another point that sometimes it is necessary
Okay,
the pod
side
balloon
branch to
marker to be
yeah, with the side branch.
distally from the
This
side
is
branch
not
balloon,
stable.
but this is not a problem because you
Okay,
have a
now
problem.
six,
We
the
have a
main vessel.
balloon into the
No,
side
we
branch.
keep the
But
six.
by, by this technique now you have a lot of balloon in the side branch, which is unnecessary
Okay,
so
and now,
much
the main
balloon.
vessel to 14.
If you have the two markers
We keep 6 in the side branch.
in
The main
if
vessel
the marker
to-
of the
you
pod
to
balloon
14.
is inside the POC,
Okay.
polygon of confluence, then you can summarize two diameters there.
Side branch,
What you have to avoid is to have a long overlap.
Yes.
Why you can put the two balloons in the POC? Because this is oval, this is not round.
No, no, okay, but in the side branch you have about
Yeah, you have
a lot of
but
balloons.
You are not obliged to go to high pressure there,
Yes, absolutely.
just to correct the place of the carena.
Exactly. This is the idea. Here we don't follow the equal pressures. We give a high pressure into the pod balloon and a low pressure just to reconfigure the ostium of the side branch. Not even usually I give 6 to 8 atmospheres, just to push the stand strut with a minimal risk of dissection in the side branch.
So the proximal marker of the side branch balloon is on the bifurcation.
Yes.
Okay.
It is the marker is inside the stand.
Yes.
Only the marker is inside the stand. You see the stand.
Yes.
The marker is placed inside the stand. Only marker.
Okay.
And the marker of the pod balloon is at the level
Of the pot.
of the marker of the side branch balloon, but because this is exactly the polygon of confluence,
Yes, yes.
which with angiography it's almost impossible to exactly assess. But the balloons are configuring just because these are two cylinders.
Good, interesting, yeah.
So,
And this is enough. One inflation,
I know. Without kissing.
Probably yes.
just
Professor Vasiliev, can I ask you, Dr. Allen, did you make this on a bench test?
yes. It is published in this article in Cardiology Journal.
Good.
You can see the bench.
Okay.
We made it with Orsairo stents. Actually, by the way, exactly with the Orsairo which they use. I mean, not this one. On our flexible models of the bifurcation. So the article is free, so you can read it without any problem.
Thank you.
Now we have, at the moment, 93. How much POCI?
I have the wire.
98.
I have the
Okay,
wire.
98
Okay.
patients, and we compare this cohort with our historical cohort with kissing. And we send an abstract for the EuroPCR now to present the data this year. We will see.
I bet we are.
And another information is the KISS trial was showed yesterday, I don't remember by whom, by Bernard Chevalier, my associate,
Are we distal?
telling that
Distal, but not so much,
kissing,
because in the shift.
when there is no tight lesion in the ostium of the diagonal branch, of the side branch, kissing is not giving any advantage.
I see, because in the
So,
pullback, the catheter will
and
get inside.
we are just closing the review at 1 year. I am part of the CRO, so I, of course, cannot give the information, but we are just closing it. It will be represented in PCR.
We appreciate your nice
1 year
discussion.
follow-up.
So-
You have seen, okay.
This is the distal vessel.
So you will have to explain what you see because, you know, I'm not a specialist. Is it on the wall or not?
We broke
Well, this is the distal vessel. We start to see the distal part of the stent. At this point, perfectly opposed. You see that it's almost OCT quality. So this high definition IVUS has really brought a difference. You can see the layers. Here you see the plaque burden. This stent is still well expanded, well opposed. And most importantly, the concerns when you perform the POCI is whether the distal pal will be deformed. It is not deformed. And here we are already at the proximal part of the vessel. I think we have to revisit.
No, we made, he passed. By the way, this IVUS is really a perfect demonstration about the ability of this technique to restore the polygon of confluence exactly without any deformation at the carina. Just really to restore if you need just to
maybe we can
restore
try to see the
ostium.
bifurcation. I skipped the
and
bifurcation.
you skip what we have clearly demonstrated with this technique, that it reduces the contrast volume because this is the pot and kissing all the manipulation at the same time, and we significantly we reduce the contrast volume, we reduce the X-ray time and the procedural time. It's true, it's 2-3 minutes, but and it is 40 seconds fluoroscopy, but 40 seconds if you calculate how many 40 seconds.
So we can conclude from this that to do a good case, you need to follow science. You need to do also tips and tricks, which are very important.
Okay. Dobrin, I have one question. Okay. In case we have 2 stents in bifurcation, we must make new carina. We can use POCI.
Yes.
Is enough. It's not necessary first kiss after that pot.
It's up to you if your balloon crosses the side branch direction. It's not a problem to use. My suggestion is to use 7 French.
7 French, okay.
Just
easier.
Easier.
Let me know if I try to see the diagonal, but
of course, I don't have the eyes of IVUS, but what I see here is a persisting carina shift. Because you can see here, to the diagonal is coming a kind of plaque coming from distal to diagonal.
You're right.
If you have a plaque shift, this is coming from proximal because there is no plaque on the carina. So we observe exactly the opposite of this. I mean, a needle coming from proximal towards the diagonal branch. So here it's a carina shift. But as it was said yesterday, a carina shift creates an oval ostium of the side branch, as it was probably nearly around before. And it doesn't change a lot the surface. And it's very rare, as demonstrated by Bonkonku, it's very rare that it is creating a clinically significant side branch stenosis. So I think even with this, we see with IVUS, but personally I won't touch that.
Yeah, but why do we have that?
There is a very small dissection at the ostium, and I think that the result is excellent at this moment. The stent is perfectly opposed proximally, distally. Just, I think that any further action could only make the results worse than now.
I also agree with Dobry, but can we see again the IVUS at the zone of the bifurcation, the ostium of the diagonal branch on the previous IVUS, just to stop there and to see it better?
Of the previous IVUS?
Yeah, so that you did the last IVUS.
IVUS pre-PCI?
The last one.
Ah, the last one.
Yeah, the zone of the bifurcation, exactly.
So it's difficult to see the bifurcation in the last pullback because we have a shadowing that it is shadowing exactly the takeoff of the side branch. So do we need to do a new acquisition of the? Okay.
Eva, what are you doing?
We're going to do a new pullback because there is a gap. Some of the transmitter is not working, and it is exactly at the side of the bifurcation. I mean, this sector where the bifurcation is originating. So we are trying to make another IVUS.
Okay. But anyway, my suggestion is not to manipulate anymore at the bifurcation.
Yes, the minimum stented area is around. between,
perfect, but it's very good.
between
Yeah.
6 and 7 distally
I think
with a post stand.
Absolutely, the
other
stand
point
is
is,
excellently opposed, totally following the anatomy of the bifurcation.
When I go to
Just don't touch anymore.
Maybe if you have a stent enhancement,
No, you have to go.
if it's possible to have a stent
Further?
enhancement, two projection will be very interesting, I think.
Yeah. Further. Yeah, you are.
By the way, with the two markers of the assist IVUS, you can
remove
make
the wire.
a stent enhancement. Yes, there is a distal. There is a yes. Because
Yeah, very good
I'm
idea.
doing that from time
Perfect.
to time, just
Yeah, good.
to yes, with this one, because it has one is the proximal marker. This is a detector. This is the imaging detector, and the distal one is at the tip of the sheet of the IVUS, and you can use it like a balloon for the stent
So we
enhancement
have
if you
some
want.
muscular bridge. there.
Yes, there is a huge
Muscular bridge.
muscle bridge. Yes.
yeah.
Yes. Now it comes a
Yes,
small
yes.
side branch
Can we have this on full screen?
in the full screen.
Screen is
So this is
one.
the distal
Ah,
part
thank you.
of the stent. See, no deformation after
Ah.
the poking. We did not. And this is our side branch, I guess. Now we could see it.
Is it malapose or no?
No. Apparently everything is fine. And this is the second diagonal branch, proximal, still inside the stent. And now we should come to the circumflex.
Great.
This pullback is much better
Great.
for educational purposes. Some plaque in the left main, but and this is the guiding catheter. Okay.
Compliments.
You can, if you can go back to the bifurcation at the carina level just to see the
Yeah.
both vessels.
Yeah. Because this was the part. But for me, it was important to highlight with this pocket technique that you invented. We are not deformating the distal part of the stent.
No, absolutely.
Exactly. And I find it extremely
is-
smart. And probably it would deserve some position in the next bifurcation
This is
club
a-
consensus.
This is a wire which is,
Yeah.
you see, because
Yeah, this is already the
wire
proximal part,
here is
so we
outside
have to go-
so you see also the
And
wire.
this is the side branch. We
Because
intend
the
to...
IVUS and wire are running in parallel, so you always see
Perfect.
the
Do we
wire.
have here, no, we have,
It's okay.
frame by frame. So, this is the bifurcation.
You can see because you
If-
this way.
Oh, sorry. But for me it was nice, very nice.
Yeah.
So you can see at 5 o'clock, more or less, you can see the takeoff of the side branch. You can see, right?
Fari, satisfied?
Нещо
А, я.
стана 1-2 часа, стента на 1-2-3 часа, не знам нещо. Добре ли е според вас? Добре да е. Да го оставим, нищо няма да стане.
Нищо няма.
Нищо няма да стане. Окей, съгласен съм.
So this here is the guide wire.
This is
Keep
a
in mind,
catch
it's
between
not
the fans.
malapose. Probably this is what Yves saw. And he said, is it malapose? But it seems to be the guide wire. which
Yes, this is the guide wire.
Exactly.
This is the guide wire what you see.
Yeah, exactly. So this is the side branch.
Yes.
And you see that it is open.
Yeah.
The access to the side branch is open enough and gets enough feeling. Keep in mind that the relevance of this of stenosis also depends on the length. If it is only obstructed in a very short segment, the likelihood that it dissipates enough energy to limit the flow is much less than if it is longer.
Iva, can I ask you to do a stent enhancement with the both markers of IVUS inside the stent?
We removed it.
But we can use a balloon.
Juan, could you...
You remove everything.
Yeah,
Okay.
no, we removed the IVUS and we have to.
we
But
can-
I think that it is.
But we can
because
use
you
a balloon. We can use a balloon
Yeah.
just for the stent booster.
Is that because you are not
We're
trained
waiting for
at
the other case.
treatment at PCI with only angio guidance? That's why.
Well, Juan, just a question. Could you say again the name of the inventor of this Pocky technique? It's very interesting, really, I appreciate. Who invented it? The name?
If you turn your head,
Yeah.
you can see him, Dobrin
Okay, good.
Vasilev.
Very good technique.
And
Really,
it was-
I will try it, for sure.
Thank you.
For sure, I
It
will
was,
try it.
it was
Guys,
published.
let's see the angio and to proceed with the lecture of Dr. Avramovic with about the X-ray protection. Just if you want, just to enjoy us with one more.
Yeah. The Pocky technique was published in Cardiology Journal in 2022 in a series performed by Robert Gill, who was also participating in this meeting, and Professor Vasilev. And I find it an extremely smart solution.
Thank you, Juan. Thank you for advertisement. Now, okay. Dr. Avramovic, please. Guys, we will leave you just to switch the patients, and we will continue here with the lecture about the X-ray protection systems. I think extremely important for every invasive cardiologist.
Thank you very much.
A must to know about the X-ray protection, because this is our health. So, Yuri?
Oh, thank you, Dobrin. Thank you, Dr. Gele, for inviting me here. This topic will be a little bit different from what you've heard before, but as Dobrin said, it's really important that we take care also of ourselves while doing interventional cardiology. Okay, so let's move on. We receive more radiation than people that go to nuclear power plants per year. And getting this dose, basically, we don't see it. You know, we work and we are fine, and we do bifurcation, CTOs, 3-hour procedures, 5-hour procedures. But we don't care, basically, what we see on the screen. You know, there is a limit, but sometimes when we are, let's say, really into some procedures, we say, oh, 2 grays, and then, you know, that's basically a lot. And we should take care about what and how we do it, and taking care of our backs and taking care of our safety. So what are the radiation exposure impact effects? Of course, cancer, cataracts, hypertension, skin lesion. This is about radiation. So it's not really nice to speak about this stuff, but the health effects of radiation is that the fact that we get 2 times the amount of radiation dose on the left side of the head versus the right, and the amount of left-sided brain tumors is 86 versus 14 left versus right. So there is the occupational risk, of course, and also the technicians and nurses are at the high hazard of occupational risk. So the US National Cancer Institute observed elevated risk of brain cancer, breast cancer, and melanoma in a cohort over 90,000 technologists who assisted in this interventional procedure. So cataracts, of course, are really important. 41% of nurses and 50% of interventional cardiologists show significant posterior subcapsular lens changes, so which is the precursor of getting cataracts. And this is particular type of opacity is the closely associated with radiation exposure. So there was also a European study about 300 responders, and basically 90% of cath lab workers are concerned about the effect of radiation. 27 had cervical spine issues. 92 believe that hospitals should do more for this occupational hazard, and 63% has suffered from a lumbar spine issue. Me too. Yeah, so I'm still young, as I consider myself relatively young, but you know, and having spine issues 5 or 6 years ago. And you know how much the apron weighs? The average weight of an apron is 10 kilos, lead. There are some who are less heavy, but still 10 kilos plus what we do have. And you know, the position that we work in, which is not really standing like right normal, like we do now, but you have this position for 2 hours, which is really not good for your back. And putting 10 kilos more up to your shoulder, it's really hazardous to your orthopedic stuff. So 84% are somehow very concerned about ortho injuries. 21 have taken health-related leave from work. 27 use the thinner apron, which offers less protection than 0.5. Just 58% wear the radiation badge at least 70% of the time. And of course, brain is the biggest concern, and yeah, possibly the least protected, because we often don't use anything for cover our head. So 21% have taken a health-related period of absence from work attributable to this occupational hazard, and 18% have to take the time away from work due to excessive radiation exposure. This is 1/5. It's a high number. So it's time to reduce the interventional occupational risk. You see these workers, you know, and we are like these kind of workers. They don't know that hate is made mainly those who can kill them. So I'm telling you about what we did. We got a new cath lab in 2017. It was a Zurion C7, C12. It was the Clarity system, ultra low dose. And we started the fluoro, every procedure with 3.75 frames per second. At first, the Philips worker said, no, it's not going to work. I said, come on, just put it, and we tried to do it ourselves. And 7.5 frames per cine. So we can enhance the radiation if we need, because we have like a mini laptop. Of those who are working on a Philips machine know that you can enhance the radiation if you need to enhance the radiation. And of course, at the beginning, we put a little bit more osmolarity contrast so that the visibility was better, but now we use 360, not 400 anymore. So this is my cath lab, and this is the view from my cath lab. So I think that no one in this room has the view like me. If anyone has it, please raise your arm. Yeah, maybe you. Oh, sorry. Okay. So when we did a study, a retrospective study, so 900 patients, all comers, 450 on the old cath lab and 513 from the new cath lab, and the goal was satisfactory image quality for evaluating coronary stenosis and PCI treatment of a lesion. So we just measured the DAP and the cumulative dose. So, you know, to account the differences, the fluoroscopy time, both diagnostic and PCI procedures were included in the study. So these were normalized and dividing them by the corresponding fluoroscopy times. And to ensure DAP per minute and cumulative dose per minute in both cath labs. And so, just to make it short, you see in the red, the new, there was a 75.6 reduction in DAP and 83% reduction in the cumulative dose, just having a new machine. Everything else was the same. The physicians, the nurses, and the flow path, everything. Just the machine and how we tweak the system get us this kind of dose reduction. That's one point. But is it time to get rid of the vests? You know, I hate vests. I really hate, because I have back problems. Whenever I do a long procedure, I really hate when I look at the vest. I hate it. Okay, and we do have some new protection that can get us rid of the vest and protect us as doctors. So first of one of these is the AgNest. AgNest is a system that you basically put it around the table, and it reduces scattered radiation. You can see on the picture how is it made, and you can basically put a table on the table and the protection all around the table, so the scattered radiation from below the table, which is the worst one and the biggest one, gets reduced. So it's really easy, so it has no workflow impact. It's versatile, you can use it for every procedure, but it reduces the radiation up to 97%, so it's not 100. And it protects everyone in every procedure. But it doesn't take you out of the lead vest. So it's very efficient, and you can see here what is the number, the reduced number for the most important thing is that also for example, if you do TAVIs, the echo guys who stand at the head get the protection, because usually they don't get the protection in this setting. So it's 97, so for a jugular access it's like 89, the scrub tech is 90, angiographer 92, and the nurse 92. Basically it's a very high percent of dose reduction, but it's not 100. So it fits seamlessly into the lab, and you can also see here the reduction about the position and the distance from the floor. So these are the numbers once again. So it protects you in every single part. It reduces the scattered radiation. So also it depends the position of the head. Also the PA gets the lower, and the LAO 40, caudal 30 has the more radiation, and also for example, when you do the laterals, they get, this is the more, but we don't use it. We rarely use it. Okay. So basically, it reduces everything that you can do in this setting, but as I said, you should wear the lead apron, because there is no way that the EC system can protect you in 100%. So we tried it, of course. We did just 8 cases, but and we did the measurements, of course, and the reduction was somehow, as in studies, about 96%. It depends on which cases we did. Basically, we did mostly some CTOs and some left mains. The other system is Rampart. I bet you heard about Rampart because it gains really popular in the last years. So you can see just a video of what Rampart does. Rampart is a wall between us and between the angiography machine. And the good thing is that Rampart, basically, it's a 2 centimeter, let's say, plexi wall with an additional bismuth inside that is produced just in one company in the world, so that's why it's pretty much very expensive, but makes a good job in protecting the people who are working on the right side of the device. So, let's say the inventor of Rampart had back problems, of course, and yeah, he was the one who basically put this machinery together, and he wanted to have a solution if there wasn't, because there wasn't one, to get him completely rid of the lead vest. So basically, you put Rampart between you and the machine, and the protection is 100%. So it's a shield that divides the chamber, basically, from the left side and the right side. And I'm emphasizing this because it doesn't protect anyone who is on the left side of the Rampart. So you can use it in all interventions using radial, femoral, pedal access, coronaries, structural, abdominal, ablations, neuro. But what Rampart can do, it's for implanting pacemakers, up and over legs, or pediatrics and short patients, so putting jugular stuff and things like that. It doesn't protect the radiographer, doing TAVIs, for example. But for pacemakers, we found a solution, so we just put the patient upside down, and we can do the pacemakers also with Rampart. Also, Rampart has a new version now coming out, which encompasses also what you've seen on the egg, but they put it just on one side. So these animations, you already seen it, and you can see here the area that it's protected. All this green area, it's basically protected from the radiation. Also, when you need some emergency stuff, you can put Rampart on some kind of small wheels. You can put it back and forth, and it's not a fixed thing, but it's movable. So basically, you do every kind of stuff. You can put CPR, and also the Lucas and things like that. So, and you can also do really, really tough angles, and it doesn't much bother the protocols. But what you need to do is you need to have, because if you are without a vest, you definitely need to know that you need a live measurement of radiation, because maybe there can be a hole, and Rampart you can put in different angles, and maybe you can have a hole and then you can get some radiation. So if you have a live radiation measurement, it's essential for not having a vest, so you know that if you are protected live or not, because if you are doing a 90 or 120 minutes procedure and you maybe have a hole, then you get a lot of radiation. The average stuff with doses is that the operator 1, gets, for example, an 0.9 microsievert, the operator 2, 0.3 microsievert, and operator 3, if there are 3 operators, you can see here, gets 0.3 microsieverts. That's, if you would do 250 cases with Rampart, that would get you 1% of annual maximum. So this is an extremely low dose. So the operator 1 average 0.9 microsievert is equivalent to eating 3 Brazil nuts. That's really nothing. So you can see here in the scheme how much radiation you can have, like natural radiation. The highest that we can get is like flying. When we fly transatlantic, we can get really a high amount of radiation. So 250 cases per year for this OP1. This average equates to 3 flights from Hong Kong to North America, which is, for us, doing 1 year. Maybe I do more flights than get the dose from what I do. So this is how Rampart basically gets us protected. This is the dose that we got from Rampart when we tested it last year. And so you can see here, it's really small. I need to look. The doses were really, really high, and the protection was like 99.8%. There were some really tight and really long procedures. Me and Gabriele were doing one really tough case at our meeting, the CTO one, which was really long, and the protection was like, the first operator got 9 microsievert and second 0.8. So the protection is really good, and the doses were really low. So the yearly analysis of this would as I told you, as in studies, 1% of annual maximum if I would do 250 procedures with the system yearly. Okay. So there are some studies, of course, and this one I want to show you that the John Lisko from Emory Hospital in Atlanta did. And they found out that Rampart significantly reduces radiation to the head, so 10 to 17 times, which is really important, and neck. And there is also 6 to 13 times less radiation to the axilla and 11 to 14 times less radiation to the forearm and 12 to 15 times less radiation to the mid-tibia. These are all areas that are not protected by our vests and our covers. So Rampart can, of course, protect us even in the areas that we are not protected. And the third one that we will be talking in this talk is zero gravity by Biotronic. The zero gravity is a system that can be mobile or it can be fixed on the floor. And basically this is a vest that is standing. You can't wear it, basically. You wear it, but someone else is holding it up for you. It has a floor unit, a monorail unit, a hinge swing arm, and a monorail hinge swing arm. So basically you can put it in your cat lap and move it around the table wherever you want, and you can put it in whichever position you want. So because it has a shield over here, it also protects the left temple, the humerus, the tibia, because those, as I told you, are the parts that they are not protected by your apron vest. So also with Biotronic, with the system, you have great potential to reduce operator dose to the creation of a nearly zero radiation work environment. And the protection is dose reduction of 83, 92, and 86 respectively for the brain, left and right eye using the zero gravity in phantom setting. And in the clinical setting, this reduction was 73, 83 procedures for this area. The area that is not protected is just the arm, which you put outside of the, let's say, of the vest. So the radiation is nearly zero radiation, and of course, you should not wear any additional vests. So this cumulative position radiation from 50 procedures that in this study was similar to the dose received during a single case wearing the lead apron, so 50 to 1. So a physician would need to have performed an approximately 50 cases with a suspended lead unit before reaching a cumulative radiation dose similar to the dose received during a single case wearing one normal apron. And also what they did is that they got across the entire spectrum of the patient BMI categories. So it doesn't matter if the patient was, let's say, big boned or thin, we got the same radiation protection. But not also the operator, because zero gravity is somehow a little bit bulky. It also protects your assistant, because the assistant needs to have a lead apron, but because this is like a shield, it protects us, but also you can see here on the last photo, it protects approximately 50% also your assistant. So an average PCI procedure is assumed to deliver 300 milligray and compose of all the projection. And so the protection dose reduction over a 25-year for a physician who perform yearly 550 PCI procedures, and the cumulative dose with using zero gravity, it's 24.8 milligrays, which is really low. And not also, it was put in guidelines. So ESVC, the Vascular Surgery Guidelines for 223, they recommended to use zero gravity in peripheral procedures, in vascular procedures. And so, but this putting in the guidelines, zero gravity now a class of its own. So, and it's put a class 2A recommendation, so that means the zero gravity should be considered in high dose endovascular procedures. also small mention is radiation, and this is a thing that you put it on the machine and it extends down, so it reduces scatter radiation, but currently is just fit to Siemens machines. So I haven't tested it yet because we have a Philips one, but I've seen data, and the data looks also promising with this device. If you want to, let's say if you fly a lot, like I do, you can have a calculator, there is on the web, and you can calculate yourself what kind of doses you get also by flying, and you will see that the doses are not that small, actually. So, which of these protection devices is the best? Well, I can't say. There is no optimal radiation protection device on the market currently. Everyone has its own strengths and weaknesses. Well, if you choose a one, you did a great job. You did a great job for yourself and for your colleagues. So, Rampart is perfect for everything done from femoral to radial and on the right side of the device for coronary, structural, peripheral. It's full protection, 100% for the whole team on the right side of the device. And the bed, it's no protection when working upper part of the body, so anesthesiologist echo, and for CRF, pacemakers, ICD, and subclavian and jugular access, and this was me and Gabriele doing cases without any apron last year. So the egg nest, which you can see here, and we using it. So the good is lowering the radiation across all sides of the table, so also the echo has its own protection, the pacemaker guys, so everyone working in the cath lab gets his benefits. So the bed, it's no 100% protection, so we need to have an apron when using egg nest, till now. And it's bulky and may interfere a little bit with workflow, although they say no, but we found out that there was some interference with the workflow. And what about zero gravity? You can see here a movie. I don't know if you hear something, but the good thing is that it's perfect for every procedure, especially good for doing upper body procedures, so pacemaker, ICD, CRT, because, and good for procedures which need partial need for radiation protection. So if you need it like when you're implanting, I don't know, CRTs, you basically do the surgical part, then you do the interventional part, and then at the end you do the surgical part. And so basically you can, you see here as, you cannot hear, so I did the surgical part, then I implanted with zero gravity, and then I finished with the surgical part. So it's really good when you need partial radiation protection. And also, it protects the head. And the bed, the protection is just for me, so the team needs an additional protection device, or the apron, even that from my protection from with the zero gravity. And it's a little bit bulky, and it's time to adapt. And we use it also in combinations. On teamwork, I think it's really good. So we did an egg nest procedure with zero gravity, and which was really extremely beneficial. So from this point, I would say that, as I stated before, if you get one, you did a good job. That's for sure. And it will get the benefit from you, your team, and everyone working in the cath lab. Thank you. We have also a conference in Porto Roche coming in March, so everyone invited,
really
you can come.
Amazed and really jealous that actually we applied now for a grant for Rampart system, and I hope that we will gain it, and we will have Rampart maybe this year, I don't know. And of course we tried now with the egg nest because they are just introducing to Bulgarian market at the moment. And as far as I know, there is one system in Alexandrovska, my ex-hospital. They have zero gravity system. So, but I don't know, are there the second one? Oh, no. Sorry? Only, yes, in my ex-clinic. They have zero gravity. And, there is such a sentence that interventional cardiologists notice the radiation when somebody obtained cancer from the stuff. And it's good to start thinking about this issue before that. I personally had a problem with because of radiation in 2022, and I was out of the room for several months. My collaborators know that this is, yes, I can say it now loudly, but in 2022, I was out from the cath lab for several months just because of the dose. And I had a really huge dose. That was not only because of the cath lab radiation, but I had several CTs because of the COVID. And in total, the radiation came to and affected the blood tests. So now we have to be, and this is, I'm talking that loudly because in general people do not notice that the radiation, you cannot see it, but it is affecting us all the time. And we should be aware about that. And especially for the complex patient operators with the long procedures, where there is really a high dose radiation. No matter you
just to say the same thing like you, it's really very important thing, the radiation. I think that we as interventional cardiologists have to be very aggressive with our hospitals, with our directors, because they have to keep us in the low radiation situation. I mean, we have to talk with them and to ask these devices. Obviously, the best device, I think, is the cocktail on the beach. And this is the other thing, you know.
But you know, as I go around proctoring really a lot, I've been to some places that they burn the patient. I said that the radiation protection begins from the beginning, to know that you can load the dose, not have like 25 frames per second, to have the protocols really with low protection. Because if you put, I don't know, I'm telling like this, if you are going near the nuclear bomb, no protection can protect you, you know. But if there is just a small fire, then you can get protected really well. And people are filming 25 frames per second, or like, and they say, oh, I'm not really seeing pretty well. And I see, oh, well, you are seeing pretty well. I mean, the picture is really good. Don't burn the patient and don't burn yourself. I mean, this is how it starts, and it should start like this. And then they come these protection devices.
I agree with you.
It's really important to tune, the first thing is to tune your machine with the lowest possible dose. We personally work with 7.5 frames per second as a working frequency, because at 375 on our machines, really the quality, it's not good for fluoroscopy. Especially for the more massive patients, it is really difficult. Orline?
You spoke about this shield protection, but there is still one more kind of protection, the collimation. If you don't work on a full screen and you just collimate the
for sure.
picture of interest, so the dose reduces very rapidly.
Yeah.
Yes, it's true.
Yeah, agree. Yeah. So all this stuff before the protection. So tweaking, collimation, and all the stuff comes before. Afterwards, we can put an additional. But the thinking in the head to reduce before even, you know, everyone should be aware. Also, the staff in the cath lab, how to reduce radiation. Not to film, for example, when a nurse gives some, you know, some stuff, some drugs in the blood, some people just film, you know, and she comes there, and you know, we need to take care of everyone.
for everybody.
Yeah.
Just a point. You showed at the beginning of your lecture a paper by Dr. Roguin from Israel.
Yeah.
Yeah. So he published a series of 30 neurological problems.
Yeah.
I would say glioblastoma.
Yeah.
And in the Paris region, and I had 3 colleagues dying from glioblastoma on the left side. And Dr. Roguin published a second paper with slightly more colleagues later, and it was followed by an editorial by an oncologist telling the following: this glioblastoma on the left side has nothing to see with hazard. This is the consequence of the irradiation on the left side of the head. But one of the 3 guys dying in the Paris region was a son, was 45, was working transiently in my place, and was the son of a famous professor of cardiology in Paris. He had 2 young children. He died he was 45 years old. So glioblastoma, if you have seen that in your practice, in your family, in your hospital, this is a terrible disease, and there is no solution today.
Okay, probably that left the audience not very in the best mood, but I think that yes,
They will remember.
it's necessary. Yes, this is a necessary session. I even wanted to organize a special symposium about the radiation protection, and Yuri will contact you maybe.
No problem.
End of the year, just because I think we miss this point of our work here in this country. I saw a lot of how the people work. Yes?
Yeah, first of all, I want to thank him for Professor Vasilis for inviting us. We work in a small hospital in Eastern Serbia, which is a long way down from your hospitals, judging by the numbers. And we are well aware of the radiation. I like radiation. This is something we decided that we're going to do. And when we started implanting pacemakers first time in 2006, we were working on a plain X-ray, which had actually a tube over our heads and a detector under us. And one time we actually took a real-time detector from the nuclear medicine, something like a Geiger-Miller counter. When you put it down, when you put the pedal to the metal, it starts screaming immediately. 2 days, we threw it out. So we all knew, everybody knew then what's happening when you put the pedal to the metal.
Okay, so
Thank
Yuri,
you.
thank you so much. Really, that was a useful presentation. So now, I would just like to ask Dr. Chilingirov to present the case, the live case, and then please take your lunches and go back because Dr. Rigatelli and Eva, they are starting with the case. Just Nikki will present the patient data. Afterwards, take your lunches and let's go back to the room just to continue with the case. Nikki?
Thank you, Professor Vasiliev. Okay, we are moving on to the next case, which is about 76-year-old male with high-grade stable angina with typical risk profile and with known peripheral artery disease, interventions of both iliac arteries in the past. He has atrial fibrillation and also known coronary artery disease. 4 or 5 years ago, LAD and right coronary artery were treated with DES implantation. In sinus rhythm with normal echo, with preserved ejection fraction, with no wall motion disorders, and with no severe valve lesions, we did dobutamine stress echo, which induced ischemia in 6 anterior segments. So this is the actual angio. As you can appreciate, there is severe proximal LAD lesion followed by a stented segment, and after that, again, another, let's say, moderate lesion. You can appreciate that also from the cranial. And the right is also affected, it's diseased. There is severe proximal lesion followed by a stent and another distal lesion. I told you that he has peripheral artery disease. You can appreciate the access site. Both iliacs are stented. There are also still another disease there. Also, the carotid arteries are diseased. So that's the case.
So we continue with the second live case. As you remember, this is a patient with a 3-vessel disease, maybe 2.5, depending on how you assess the circumflex lesions. And there were 2 severe lesions in the right coronary with instant restenosis. And then there was a stenosis on the LAD, mid-LAD.
You want to zoom or not? No?
No.
No.
Just a small injection. So there is also tight bifurcation stenosis on the LAD. And so that's it. I see that Gianluca already fixed the right coronary artery. There is some cloud in the distal posterolateral branch, intramyocardial.
Yeah, it's intramyocardial. We just do a little bit of sealing with a balloon, and then we jump on the left system.
Yes, the right coronary practically at the moment is fixed, and there
was a stent previously, an Orsiro 3.0 in the middle segment, and there was a tight stenosis, subocclusive one at the outflow and inflow of the stent. The stent was widely patent anyway.
I personally, in our lab, what we do now is, in those cases, is to use the trompe aspiration catheter, usually export, and then go to the as distal as possible, and then to inject gel foam at the distal part of the vessel.
Well, we just, to travel
to be sure that it is closed.
An export catheter till there to distal. I don't think that we have all this strength through the previous implant stent that we cover with 2 long stents. So I prefer to just do small dilation with 1.5 balloon and just to seal.
1.5, 15?
15.
1.5, 15.
Yeah, good. All right. All right.
So
okay.
what is your
We
plan
will do
now?
an echo just to be sure that there is not too much.
During the manipulation of the wire, although the wire was
yeah, it's clear how it is the wire.
Yes, it was wood, but anyway, there was a staining of the myocardium there. And what we are going to do is probably we have a wire, we have a balloon already, but I'm pretty sure that it is not slipping somewhere else. It is in intramyocardial, but we should check with echo. And in this situation, if there is a pericardial effusion, probably we should go, and in these situations we are going with coils. But what I propose, let's continue with the program. We'll do the echo, and after that we'll come back to you.
Okay.
So I make a very simple case very tough, because here we perform a diagnostic of a left system. You see there will There was all stent on proximal middle LAD with a tight stenosis before and a tight stenosis after the stent. This is a reverse spider that we use, is a spider, but on the reverse side, we use to see usually the ostium of the LAD and the circuit that are okay. This is a right anterior oblique 30-degree projection, and you appreciate here the tight stenosis at an inflow of the stent, at the outflow of the stent. That was the target lesion for the case today, but unfortunately we had to fix this right coronary artery. There was an Orsiro 3.0 stent at the second segment with again a subocclusive lesion at the inflow, at the outflow of the stent. Was an old stent. The plan was to go very quick and to put another, to cover all the region with a new stent with different drag. And I was so fast that probably this is all the predilation with 2.5 high atmosphere, and again with a 2.5 higher atmosphere than before. And after lesion preparation, we put 2 Xience 3.0 by 33 millimeter stent with an overlapping of 1 millimeter more or less. And the result was we were probably too fast, and the result appeared okay, but it was okay if we finish here. But on the cranial projection, there was a staining on contrast, probably caused by my loop wire, because the wire was looped, but was looped deeply into the PL branch. The PL branch was, very small, so probably even with the loop, there was a dissection finishing in a staining on contrast into the myocardium. Echocardiography was negative. There was nothing to the pericardium, but after an attempt of the sealing with a 1.5 balloon for one minute, 2 minutes, there was still staining of the contrast, and we felt more comfortable to end the procedure of today. The patient has got a chronic renal insufficiency, so we have to save some contrast. So we finished the procedure with a coil, and we aborted the rest of the procedure just because of the contrast and also because of the opportunity, I think. Here I am in another branch here. We are in the safe place to release coil, but because we don't felt sure of about the plane of dissection was, we put 2 coils, 2 concerto coils, 4 by 8 by 10 millimeter, 1 more distal here, and 1 more proximal here. And after the second coil, and after waiting 2 minutes more, we obtain a good sealing of the artery. The flow disappeared. There was really just a little staining, but from the contrast before, but the brack was sealed. So I'm so unhappy because I can't finish with the plan we have to before, but Anyway, you saw something that can happen normally.
Shit happens.
On the shitting days.
No, but we decided with Gianluca that probably it is better to postpone the procedure because of the contrast issues and the renal insufficiency. And the second thing is, when we go on the left main, if quite rarely this could happen, something happen with the pericardial effusion, that will put you in a, let's say, in a
trouble the patient
in an
with-
easy
yeah,
position.
yeah.
So we are going to deal with this left coronary on Monday, and Gianluca can stay with us for
To make another trouble.
no, just to finish the case. Okay.
Anyway, the result from the right, and that was a good demonstration how to manage with the complications, because it's rare, but it happens. There are different strategies. Unfortunately, we had quite a good experience with this type of complications. My personal strategy in our cath lab is just to go as distal as possible with export catheter and to inject gel foam. No, gel foam. We just we make it, and we previously tried to inject gel foam through the microcatheter, but it is not good. And but with, for example, export catheter, this is very easy and effective. Just to inject 1 milliliter of gel foam, and that's enough to close any distal perforation. And the advantage of gel foam is that it is resorbed in 2 weeks. So after 2 weeks, you don't have any material there. It is resorbed totally, and the vessel is opened. This is why I personally prefer this type of closure of.
Put it there, not proximally.
Yes. Yes, you have to be careful. Yes.
I agree, but here the problem probably is that I felt difficult to put the aspiration catheter so deeply in a so small branch, because it was a PL, it's not an AVP. So we felt more comfortable with this kind of strategy. But anyway, all the ideas are good.
Yes, absolutely. So thank you, Jackie.
See you upstairs.
Yes, thank you.